So in this Insta lecture session, I'm going to do a super quick review of what are the things we learned about the plasma cell myeloma or multiple myeloma. It's also known as Kahler disease, KAHLER disease, or myeloma not otherwise specified. And currently, the preferred name for multiple myeloma is not single myeloma but plasma cell myeloma, PCM. WHO preferred name is plasma cell myeloma, and also known as Kahler disease. Second thing I discussed in the previous lecture that it usually presents with crab lesions, C for hypercalcemia, which is usually due to excessive osteoclast activation, which erodes the bone and brings more calcium in the blood. R for renal failure. Renal failure, I mentioned the most common cause is light chain proteinuria. Light chain proteins, actually they are toxic to the renal tubular epithelial cells, and this tubular cast formation they usually causes obstruction also. Other causes of renal failure could be hypercalcemia, could be infection, particularly the bacterial pyelonephritis, and obviously the associated AL type of amyloidosis. A for anemia, usually the most common type of anemia we see is normochromic normocytic anemia, which is really seen due to the displacement of normal cell population, which gets crowded out by these cancerous plasma cells which are proliferating the bone. And B, the last B of crab, stands for bony lytic lesion. I have modified this crab a little bit. Nowadays I call it IAM crab. I stands for infection, AM for amyloidosis, and then this AB follows. So these could be the manifestations which are associated with plasma cell myeloma and multiple myeloma. By the way, the infection is the most common cause of death in plasma cell myeloma or multiple myeloma patient, and the number one cause of infection is usually the suppression of the humoral immunity. Now there are a lot of immunoglobulins, they are there, this M spike is there, but they are no good for us. The cancer cells don't want that we should fight in a better way against the bacteria. They want that we should get killed. So obviously the immunoglobulins which these cancer cells are producing, that is no good for us. They are not doing any philanthropic activity there inside of my body, inside our body. So obviously what they're doing, actually these immunoglobulins which are produced, they are functionally defective, and as they're functionally defective, obviously now they have plenty of immunoglobulins in our body, but they are useless for us, and that results in suppression of our normal immunity function. And obviously as there is less amount of functional immunoglobulin present in my body, that results in the patients become more vulnerable to the infections in this plasma cell myeloma or the multiple myeloma patients. And the most common site, which I also mentioned in my previous lecture, of this osteolytic punched out characteristic osteolytic lesion is the vertebra, particularly the lumbar vertebra. But it can also involve the rib and skull. These are the top three sites. VRS, vertebra, rib and skull. Remember by voluntary retirement scheme, VRS, by this way. And obviously the other things that you need to keep in mind, that the most common, this M spike, the monoclonal protein which is synthesized, the most common is immunoglobulin G, which is seen in plasma cell myeloma, compared to its differential diagnosis, Waldenstrom's macroglobulinemia, where the most common is immunoglobulin M, and that's why hyperviscosity syndrome is typically associated with Waldenstrom's macroglobulinemia. The least common is immunoglobulin E in case of plasma cell myeloma, and A is the second most common. So most common is G, second most common is A, least common is E. And please keep in mind the Waldenstrom's macroglobulinemia, where the most common is M, because it's a pentamer. That's why they make the bloods more thick and causes hyperviscosity syndrome more commonly, which is seen in Waldenstrom's macroglobulinemia, a differential diagnosis of plasma cell myeloma or multiple myeloma. Then plasma cell myeloma, multiple myeloma causes 1% of cancer burden all over the world. Median age of presentation I mentioned, this is 70 years. And basically essentially it's a cancer of plasma cells which originates in the bone marrow. These are the basics we discussed, and characterized by monoclonal protein spike, M protein. Now coming to the other features, coming to its diagnosis. Diagnosis is the key feature. On peripheral blood smear, you would be getting the rouleau formation, which is a stack on coin appearance due to the sticky immunoglobulin G, which immunoglobulins which would stack one RBC after another, creating that stack on coin appearance. You can see leukoerythroblastic picture, that means immature form of RBC, immature form of WBC on the peripheral blood, because all this normal cell population is actually getting displaced and they could be kicked out into the peripheral blood in these patients. On the bone marrow, be getting characteristic features. You could be getting more than 10% clonal plasma cells, which is a characteristic diagnostic feature for plasma cell myeloma. It is not 30% right now, it has become more than 10% as per the current guideline. And you can see a lot of abnormal form of plasma cell. You can see some morula cells, grape-like clusters, so the immunoglobulin is seen on the cytoplasm. You can see some characteristic intracytoplasmic inclusion body, Russell body, sometimes could be located apparently on the nucleus. It is called Ducher bodies, DUTCHER. Russell bodies can be seen. Flame cell can be seen. Flame cell is mostly made with immunoglobulin A, IgA, keep it in mind. So morula cells, Russell bodies, Ducher bodies, flame cells, this could be sometimes could be crystallized formation of the immunoglobulins can be seen in the plasma cells also. And plasma cells in the bone marrow, they can look like normal plasma cell and they can look like abnormal plasma cell. I discussed this thing in my previous Insta lecture. You can have a look at that one in case you need to know about this. The other points is this, that immunophenotypic marker, this is very important. Usually the plasma cell, they usually express CD38 and CD138. CD138 is also known as SYNDECAN1. And interestingly, normal plasma cells, they usually express CD19, but plasma cell in plasma cell myeloma, multiple myeloma, they are CD19 negative. This one you need to remember. And they can also express CD56 and CD117. CD117 and CD56, these are the aberrant expression. So these are the markers, immunophenotype markers, that you need to keep in mind. More commonly we use CD138 or SYNDECAN1 for the quantification of the plasma cell in case of plasma cell myeloma. Other test I mentioned in my previous lecture also, that is serum protein electrophoresis. You can do urinary protein electrophoresis, and immunofixation can be done to know what exactly the type of immunoglobulin which is there elevated in the patients of the plasma cell myeloma, multiple myeloma. And the other key aspects which you need to go through is their presentation. I already mentioned. The key manifestations are obviously recurrent infection, renal failure, then there is bone pain, chronic nomocytic anemia, and the punched out osteolytic and osteoporosis and pathologic fractures. This would be the typical elderly patient, which should make you suspicious about plasma cell myeloma or multiple myeloma in these patients. There are certain markers are also there. The serum beta 2 microglobulin that is used as a marker in these patients, and serum level hypercalcemia would be seen, because obviously the increased osteoclastic activation. Certain cytokines you need to keep in mind, interleukin 6, which is thought to prolong the survival of these plasma cells in these patients, of the multiple myeloma patients. And regarding the plasma cell myeloma, multiple myeloma, there are certain other terms that are sometimes used. One is smoldering myeloma. Smoldering myeloma means it's an asymptomatic form of plasma cell myeloma. So plasma cells could be more than 10%, but less than 60% in smoldering myeloma. The serum immunoglobulin level could be, these Ig levels which you test could be more than 3 grams per deciliter. But in smoldering myeloma, there will be no Crab features. There will be no feature of end organ damage, which differentiates it from plasma cell myeloma. Some form of plasma cell myeloma are called non-secretory, that you don't see any M protein in their urine or the serum. And previously they thought to be 1%, but late studies have seen that they could be up to 3% of the patients, which you see this non-secretory myeloma. Another term you need to know is MGUS, monoclonal gammopathy of undetermined significance. This is a kind of pre-malignant lesions for plasma cell myeloma, because these conditions could develop into plasma cell myeloma. The risk is there, so you need to monitor them. And they have elevated level of M protein, but not as high as plasma cell myeloma, and usually they never have the bone marrow plasma cells will be less than 10%, and the serum, and there are no features of end organ damage. So these are the key concepts that you need to remember of the plasma cell myeloma. I'd continue this with further discussion on the plasma cell disorders. Thank you very much.